My topic today is the transformal approach for the recurrent disc prolapse. By definition, recurrent disc herniation is the herniation of the disc fragments at the same level with reappearance of radicular pain again, but with a pain-free interval and also with MRI confirmation of the disc fragment. And in literature, the incidence of recurrent disc prolapse has been quoted to be around 5 to 15%, and that is across the span of different procedures, different way of operating, different way of discectomies together. And the time duration may vary from 2 weeks to 8 years. It can be as short as 2 weeks, but even if there is a disc prolapse even after 8 years at the same level, you can still consider it as a recurrent disc prolapse. The predisposing factors, elderly, because the high chance of disc degeneration, so likely there will be a cause of fragmentation of the nucleus or the hyaline cartilage, and they can end up with a recurrence. Trauma, that's the most common cause. Smoking by accelerating disc degeneration and preventing annular healing. Obesity, again, it's because of the increased disc pressure as well as decreased muscle tone. So these are the predisposing factors, personal predisposing factors. But we have a few radiological as well as morphological predisposing factors which you observe on an X-ray or an MRI. Should always suspect that this patient is more likely to have a recurrence in future. So the most important of them are the modic changes. Now modic changes which we sometimes see in MRI images, mainly the type 1 and type 2 images, type 2 changes are the one which can predispose to recurrence, and type 1 where there is vascular proliferation and there is weakening of the end plate and bone junction that can cause disruption of the end plate, and you can see in such cases the cartilage fragment which prolapses usually has a cartilage within that. The grade of disc degeneration, again Fuhrman criteria, grade 4, grade 5 types of disc degeneration where there is no morphological differentiation between the annulus and the nucleus pulposus. These types of discs are again prone for recurrence. Increased disc height index, patients who have the height of the disc is higher because of the increased mobility, they are prone for a recurrence. Similarly, increased range of sagittal motion, also more than 10 degrees, can predispose to recurrence. And accompanying that will be some degrees of micro instability which we can expect because of the previous procedure. And of late there has been more talk of pelvic incidence and pelvic incidence lumbar lordosis angle, and any decrease in pelvic incidence can also accelerate disc degeneration, thereby causing prolapse. Now, of course, there have been some studies depending on the technique what was used for the primary surgery as well as the skills of the surgeon involved. And Waters et al., he had in 2008 did a meta-analysis of the literature where they compared aggressive discectomy with a large annulotomy as well as with a conservative fenestration and fragmentectomy. Normally, our logical thinking is where we are minimally invasive, supposed to be that the recurrence should be lower. But surprisingly, they found that aggressive discectomy with a large annulotomy had less chances of recurrence as compared to fragmentectomy. Barth et al. In 2008, they conducted a randomized clinical trial with almost a level 2 therapeutic evidence, and they also noted no significant change in the type of procedure what you do and the chances of recurrence later. And as the era of endoscopy dawned, then as more and more disc surgeries were performed by endoscope, there was a comparison study done by Lee et al. In 2019 comparing the different types of endoscopic surgeries like transfemoral inside out, transfemoral outside in as well as interlaminar, and they found an increased incidence of around 11% in transfemoral inside out compared to 7% in interlaminar. Now the pathogenesis, as I mentioned already, the main culprit is modic changes. If you see in some patients, then always you should explain to them that there is a high possibility of them having a recurrence. And I mentioned earlier, that's mainly because of the weakening of the end plate and the bone junction, which compels the fragmentation of the disc, and what fragment you see is mainly a hard disc. And this causes microfractures, as I mentioned, fragmentation of the end plate cartilage. The nucleus pulposus fragment is usually because of trauma and increased disc pressure, more of a sudden activity, a sudden lifting of weights. Assessment. This should be the main area where whenever a patient comes back to you with pain, with radicular pain, with a similar looking pain, the one thing what you should always think is whether is it just a recurrence of symptoms what the patient has got, or is it a recurrence of disc prolapse. So we see, like transfemoral endoscopic surgeons, we are taught with a different philosophy, and whenever a patient comes to us with a radicular pain, we usually examine them with these criteria, where we expect an annular rupture, which leads to chemical radiculatis, or a patient who already undergone a surgery, because of a sudden activity, there could be some shear traction injury to the nerve root and disc interface. So all these patients present with similar radicular pain. We confirm that with Gore sign and give a distal nerve block over sural nerve, deep peroral nerve, and most of the times the pain gets relieved. In case if the pain is not relieved, then we give a foraminal nerve root block with a steroid and a local. And in case most of the time, if it's mainly a recurrence of symptoms, not any prolapse, then the symptoms usually resolve. And if you notice that there is no resolution of symptoms, then I go ahead with an MRI to confirm the diagnosis. Coming to the transformal approach, this is the most simplest, easiest, and I can say the correct way of dealing with a recurrent herniated disc, because the route of approach what we are taking is virgin. So there are no scar tissues there, there is no adhesions there. You are doing this surgery as you are doing for a primary surgery. So this is the most convenient way of dealing with a recurrent prolapse. You can imagine anybody doing a midline surgery, it's a horrendous job to open it up all again, separate the scar tissue, identify the nerve root, retract, and then go to the disc and remove the disc. But then transfemoral, it's easy, you're bang on the disc, and it can be done in a very easy way. And it can be done with we can deal with all types of herniations, whether in the horizontal plane or the sagittal plane. The horizontal, I mean the central disc prolapse, paracentral, foraminal, extraforaminal, or in the vertical plane either submigrated or down migrated. But however, we need few extra instruments as compared to a primary surgery. We may need some curettes, we may need a hook and a burr sometimes, because if there is a collapse of the disc, then we need to open up the foramen, do a foraminotomy, and then put the instruments in. RF helps you and it helps you in handling the bleeding around that area, and at the same time it helps you in delineating the tissues, because you will expect some scar tissue there, some adhesions there, and RF is a very beautiful instrument to separate the tissues without causing any neural injury. Start. Advantages, as we all know, it's less trauma to the tissues, and because we are going through a different route and we are not disturbing the posterior structures, the spinal stability is well maintained. Less operative time. I'm sure the transfemoral surgeons here, they would have taken as less as 10 minutes to complete the surgery, but the average time is around 45 minutes, so we can complete our surgery within that time. And no dural injuries. I don't think any transfemoral surgeon has ever seen a dura, I mean to say a dural injury, because it's not possible to tear a dura here, and less bleeding, and at the same time the chance of infection also are less. So I can confidently say that this is approach of choice in case we are trying to operate on a recurrent disc. Of course, there are some difficulties, but then for a surgeon who is experienced, who have done more cases, they can easily overcome them. And the main thing is the collapse disc, because if the initial fragment was a very large fragment, then you expect some collapse of the disc. And in transfemoral, sometimes it becomes difficult to introduce the instruments into the disc space. Patient may have little pain because we do under local anesthesia. Marginal end-plate osteophytes, if they are abutting the exiting route, and in some areas it might be a little difficult to reach those areas with transfemoral route. So you need to there are burrs, we can, with experience, after doing many surgeries, we can handle all these things. Facet arthropathy, again, sometimes if the facets are very broad, then they may direct your instruments more ventrally, so they can take you away from your target. And several procedures can be done through this approach. And as I mentioned initially, the transfemoral root block, which is quite routinely given in most of the patients. And as Dr. Palni also mentioned, where for HIZ, we can always treat with annulectomy as well as neurolysis. Fragmentectomy is the most common procedure done. And we can supplement it always with foraminotomy, foraminoplasty as and when required. Collapse disc space, as we did a pre-launch couple of days back, a standalone cage, Vajra, and the endoscopy-assisted transcameral fusion as well. My experience has been like I have maybe around more than 2,000 transfemoral surgeries, and my recurrences I've seen only 5, and all have been dealt again with transfemoral endoscopy only. And sometimes to minimize the chances of recurrence, we have developed this Derwan plug, which is a PRP plug, which we inserted into the area where we created the rent. And have time?
Please summarize.
Okay. This is one example of that, maybe a small video. Okay, I skip this, maybe I'll take the other one. This again, the see a recurrence there, paracentral. Okay, can play this video. So the initial preparation will be removal of all the scar tissue, because you cannot delineate the layers of the epidural as well as the annular as well as the disc tissue. So when we do that, I'll take you to the fragment. Sorry.
Please summarize.
Okay, thank you.